on behalf of the Private Practice Pediatricians Group, I would like to formally welcome us to the lecture series. Today, a young and dynamic pediatric cardiologist in the person of Dr. Chinyere Uzodimma, who is a consultant pediatrician and the founding medical director of Exeter Children's School in Surulere, Lagos. She will be talking to us today. And in our usual tradition, before she starts, we would like to yield the floor to Dr. Mobolaji Lawal to say a few words to us. So I hand over to you, sir.
Good afternoon, everyone. I hope you can hear me.
Yeah,
can you hear me? Am I audible?
We can.
Okay.
Yes, sir, we can.
Okay, great. So good afternoon, everyone. I welcome you again to this meeting. It is the fourth in our series of webinars, and I welcome Dr. Chinyere Uzodimma, who is a pediatric cardiologist and who is going to address us today. I want to say that I commend her courage in coming up, and through that to encourage others to please come up. We need to volunteer. We need people who will make presentations for September, October, November, and December going forward. I have, there's a piece of, I don't know how many heard, but, one of our colleagues lost her husband recently under tragic circumstances. Dr. Abimbola Mabokunje, her husband passed on, past couple of weeks. So I would like us to maintain a 1 minute silence wherever we are, and pensive in the honor of her husband who has just passed on, before we continue. May the soul of engineer Dr. Afolabi Magbokunje rest in peace, and may God comfort our dear colleague, Dr. Abimbola Magbokunje, and may God give her the strength and the fortitude to deal with life at this very difficult time and going forward. Amen. So, ladies and gentlemen, it gives me pleasure to welcome you again, and I hand over to Dr. Eletu to continue with the meeting. Thank you.
Thank you very much, sir. So, Dr. Uzodimma Chinyere, you have the floor.
Thank you, sir, Dr. Mobolaji Lawal. Thank you, Dr. Eletu. Thank you for the opportunity to speak on this forum. I want to just recognize the presence of Professor Bode Thomas, who is my teacher and my mentor. I saw that she entered the meeting room, and of course, to recognize everyone here and to thank you all for joining. So today we are discussing cyanotic congenital heart diseases, unmasking the two-faced masquerade. You know, when I was called up to speak on this forum, I went into some thoughts. What would be the message that I would want to pass on to my colleagues? And I felt I needed to find something that each and every one of us would, at the end of this meeting, have something practical to start doing or to continue to do better if we were already doing it. So it is not a meeting of too much English or highfalutin things. It may just be something that you know, but it is important that we remind ourselves about them. One of the major inspirations that I had, things that inspired me to this topic, is the fact that a couple of times I have received referrals of children at 5 months, 4 months, 6 months, who for the first time their parents are getting to know that they have an underlying congenital. And not only are they just getting to know by that age, they're getting to face the fact that they need to plan for surgery as soon as possible. So I thought that this might be a forum for us to look at what happens in cyanotic congenital heart diseases that sometimes make us clinicians sometimes to miss the diagnosis at an early age, you know. So that is the major stimulation for this topic. So I termed it a two-faced masquerade because cyanosis and cyanotic congenital heart diseases, most of us would remember that as a condition that usually is openly manifesting, you know, it's not hidden. However, if we have some that are being diagnosed at 5 months old, it means that there's another face to it. There are some of them that may hide somehow. And then looking at these two faces, the ones that are very obvious and the ones that can hide, is the major focus of this meeting. I have been asked to do this within an hour, and this is to include also the discussions that surround it. So it will not be exhaustive, but at least it is going to whet our appetite. So I will go on now. So I have 2 cases here to present, you know, 2 cases selected from a number of them. And the first case is a 4-month-old baby A. Baby A presented with a history of fast and difficult breathing of 16 hours. The symptoms were said to have started shortly after a feed, and there was no history of fever. The mother was rushed to a nearby hospital. The baby was rushed to a nearby hospital, sorry. The baby was cyanosed and was desaturating to 50 to 60% on room air. The hospital made an impression of severe aspiration pneumonitis, nebulized the baby with salbutamol, budesonide, ipratropium, went on with oxygen as high as 10 liters per minute on improvised CPAP, commenced antibiotics, but still the saturation did not improve. At the time of referral, they felt that this baby needed a ventilator based on severe lung manifestation of aspiration pneumonitis, and they referred to it. Now, when we received the baby, was first seen by a pediatrician, and still on further questioning, the mother insisted that the baby had been well. until just a few hours prior to the symptoms. And it was also emphasized that he was fed shortly before the onset of symptoms. The key physical findings were severe respiratory distress. The oxygen saturation on room air was 54% and went up to 86% on oxygen. The respiratory rate was 64 cycles per minute, and there was tachycardia of 172 beats per minute. The baby had a hepatomegaly of 3 centimeters, and it was queried to be tender. An initial impression of possible foreign body aspiration was sustained, and to rule out acute epiglottitis, and the second diagnosis was heart failure. Further actions taken include sepsis workup. That was over 20,000 with neutrophilia and a C-reactive protein of 120 milligrams per liter. The EU creatinine were normal. Urgent chest radiograph showed no lung lesion and a normal cardiac cilia. The X-ray post-nasal space showed adenotonsillar enlargement, and X-rays of the neck did not confirm any acute epiglottitis. Now, the initial treatment, the baby was sustained on oxygen therapy and CPAP, IV antibiotics, intravenous furosemide was added, and then the baby was reviewed by myself on day 2. And the saturation was 70 to 84, even at 10 liters per minute on CPAP. The respiratory rate was 48 cycles per minute, and there were bibasal crepitations. The liver was 5 centimeters palpable and tender, and the baby had a cardiac murmur. But the packed cell volume was 52%. You will get to understand later why I put this in exclamation. A bedside echo was immediately done. Guess what was found? This baby had a complex cyanotic heart disease, had a tricuspid atresia together with transposition of the great arteries and other congenital heart defects, including an atrial septal defect, a ventricular septal defect, and mild pulmonary stenosis. And this baby needed surgery and further investigations, catheter-based investigations. The ECG of this baby showed right ventricular hypertrophy based on the R voltage in V1 and increased RS ratios in V1, V2, and V6, and there was right axis deviation. The image here shows the ECG of the baby we're discussing. And if you look at the lead 1, you would see that the lead 1 puts that, if you're plotting it, I don't know if you remember this, but this is a predominantly negative deflection. And you look at AVF, you also have a predominantly negative deflection. With this, it means that this baby's QRS axis is actually in the right upper quadrant, about 243. And then obviously increased voltage, R voltage in V1. Increased R voltage in V1 suggests that the right ventricular force is actually strong enough, to manifest with a prominent R wave in V1 and then V2, and this suggests a significant right ventricular hypertrophy. And if you look at V6, By the age of 4 months, the left ventricle is actually supposed to be the dominant ventricle, and we're supposed to have a predominantly positive deflection of the QRS wave here, which is the R voltage, but we're having a predominantly negative deflection also in support of right ventricular hypertrophy. So this was about baby one, case one that we have discussed. Then the similar case, or on the other side of this masquerade that we're discussing today, is the second case, baby O. Baby O was one of a set of twins and weighed 2.45 kilograms at birth. Our team was invited for mobile bedside echo on a 5-hour-old newborn who continued to desaturate despite oxygen, and the SpO2 was as low as 50 to 60%. The echo finding of this baby showed pulmonary atresia with ventricular septal defects. The pulmonary arteries were supplied by a small PDA, and the VSD was small and restrictive. And by the way, this is also a variant of tetralogy of Fallot, which we call tetralogy of Fallot with pulmonary atresia. So sometimes it can just be considered as pulmonary atresia with VSD, or sometimes it can also be considered as tetralogy of Fallot with pulmonary atresia. They're all the same thing. So, having conducted echo on this baby, we advised oxygen to be discontinued because this baby needed to have that doctors to remain patent. Baby was transferred to another facility for an urgent blelotoxic shunt. And while on transfer, had prostaglandin infusion. This BT shunt was done on day 2 of life. The essence of the BT shunt was actually to supply the pulmonary arteries, because we say this child has pulmonary atresia. It means that there's no way for the right ventricle to push blood across to the pulmonary arteries. And the pulmonary arteries were being supplied by a very small PDA. And if that PDA closes, then the baby would no longer be able to continue to survive. So the essence of the BT shunt is to provide a shunt that would ensure blood supply to the pulmonary arteries. In other words, a way for blood to get to the lungs and get oxygenated. So after this BT shunt, the oxygen saturation was 82 to 89% on room air. The baby was discharged on the 6th day of life, and later on, at 4 months old, went on to have balloon valvuloplasty. The baby is alive and well too. So BT shunt was like a temporizing procedure or palliative procedure, an immediate life-saving intervention that was done in order to be able to allow the baby to continue to survive since the. Okay, so now going into the depth of this presentation, I will just remind us that cyanotic congenital heart diseases are congenital heart diseases which are associated with cyanosis. And this cyanosis is usually due to systemic blood flow bypassing the lungs or mixing of oxygenated and deoxygenated blood. And to remind us also that congenital heart diseases are congenital by virtue of the fact that they are present at birth. It is only their manifestations, the clinical manifestations of congenital heart defects that arise at variable times or at variable age. But the fact that the defect is present at birth is sacrosanct. But some may manifest immediately at birth, some may manifest at 1 week, some may manifest at 6 weeks or thereabouts, So, what is the classification of cyanotic congenital heart defects? I want us to look at this chart so that we can understand why some people will come to us at 2 years old, they are fine. while some people are born and they're in trouble from the first day of birth, looking at the two case presentations, you will see that the second case presented was in very big trouble, life-threatening situation in the first day of birth, while the second person was okay and, apparently looked well and normal to the parents until the child was diagnosed at about 4 months of age. So it is because under cyanotic congenital heart defects, we have some of them that present with decreased pulmonary blood flow. We have some of them that present with increased pulmonary blood flow. We have some of them that present with pulmonary venous hypertension. For those with decreased pulmonary blood flow, we need to appreciate that decreased pulmonary blood flow can be considered as a spectrum. For some, there's no blood flow at all. For those ones that are really critical cyanotic congenital heart disease, just like the second baby presented, there was no pulmonary blood flow at all, apart from a small ductal shunt that ensured that some kind of blood still got to the pulmonary circulation for oxygenation. So under here, we have tetralogy of Fallot, double outlet right ventricle, pulmonary stenosis, tricuspid atresia, pulmonary atresia. These are the conditions where you have decreased pulmonary blood flow. We have some that will present with increased pulmonary blood flow, and this is classically where you have transposition of great arteries. So while in those with decreased pulmonary blood flow, they look well because their lungs are clear. They don't have any problem, apparently. And that's why most of our TOF, except if they have very severe pulmonary stenosis, they don't tend to develop symptoms before the age of 6 months. Their symptoms come on later, after 6 months, some up to 1 year before they become symptomatic, So, and that is because their lungs are fed, they don't have congestion. But in this second group, increased pulmonary blood flow, they have congestion. So the child with transposition of great arteries will actually become symptomatic within the first week of life with heart failure. And if they become symptomatic within the first week of life, it's important for us to understand that the timing of surgery or intervention for transposition of great arteries is typically by 4 or 6 weeks, typically by 4 or 6 weeks. So it means it is not a kind of diagnosis that you want to be making by 2 months old or 3 months old, particularly in an environment where when you make the diagnosis, the parents have to go home, consult their community before they can, move forward. And that is why I think the most important thing that spurred me to make this presentation is to stimulate us so that we'll be able to make diagnosis early so that the parents can have time and be able to save the children if they can, So this is also where we have things like persistent truncosarteriosis. It's also one of the conditions that would manifest early. But however, persistent truncosarteriosis can be very tricky because in persistent truncosarteriosis, you just have mixing in the great vessels. And most times those children may saturate above 90. They may have a saturation of 91, 92. And if you're not careful, you're just saying that it's not much, you can go away. But it's important to actually identify why the saturation is low in the first place. And they also belong to the group that floods the lungs. All the groups that flood the lungs need an early surgery. Apart from the fact that they flood the lungs, the major hemodynamic changes that they come with entail that an early surgery should be done so that the heart can adjust. Imagine the child with transposition of great arteries. The great arteries are switched. You're going to have an arterial switch procedure, and you want to make sure that the ventricles are able to continue with this function. So the timing of the surgery is also very important. Sometimes I feel like crying when I see a child with TGA coming to the cardiologist at 4 months, and you're just wondering, what are we going to do? Or a child with persistent truncosarteriosis. So under those with pulmonary venous congestion, we have those with hypoplastic left heart syndrome or left heart. So having looked at all this, just a breaker, which of these congenital heart diseases would you pick if everyone was to choose one? I once had a child who came at 5 months old. The child was born with tricuspid atresia. And luckily for the child with tricuspid atresia, he had an atrial septal defect, which was a life-saving shunt for the baby. So the baby was not noticed. The cyanosis was not noticed until about 5 months old, when the atrial septal defect was getting smaller and about closing. The child became more cyanosed. And then the parents also began to notice that this child is looking, the color of the lips is no longer how it used to be, and they began to ask questions. That was how they landed, and they were able to have an echo done, which confirmed that the child had a tricuspid atresia. So, but even though this tricuspid atresia can allow a child to remain, alive and okay for a long time, in case 2 that had a pulmonary atresia, the lifelong outcome of the child with tricuspid atresia is also not encouraging, because oftentimes they will need to have more than one stage of surgery, to live. And then the lifetime survival and prognosis is not as good as this particular child that had pulmonary atresia that needed an urgent surgery. And I mean, for that child, the child is much better off, than any other person. So we'll go on, and then he will know which one is better to have, So it is important to talk about critical congenital heart diseases. These are cyanotic congenital heart diseases that require surgery or other procedures for treatment within the first year of life. Oftentimes, the definition is within the first year of life, but oftentimes these things are required within the first week, some of them within the first few days, like as immediately as possible, soon after birth. It is important to say that about 24% of babies are born with critical congenital heart diseases. I remember doing an echo, somewhere on a baby who was born. The baby was desaturating on oxygen, on CPAP, on everything. The baby was kept desaturating. And I was invited to do an echo on this baby. And lo and behold, this baby had transposition of great arteries with intact ventricular septum. Now, if a child has a transposition of great arteries with intact ventricular septum, it means that the child is just having a parallel respiration. The only surviving thing that allowed the baby to be born alive and not be born as an IUD, intrauterine death, or die immediately after birth is the small PDA, which oftentimes will just last for some time and then they go on to close, physiologically. So, at the point that this diagnosis was made, it was obvious that we're dealing with a critical situation. This child needed to have either an atrial balloon, atrial septal balloon septostomy in order to continue to be alive, or to have an outright total correction. But at this point, the parents were like, they can't afford this, they can't do anything, they don't have the money to start looking for solutions for anything, and they just opted to stop every treatment and then accept the situation as it were. And I think 2 years later, the mother came back again. She was pregnant and she came back for echocardiography, while she was still pregnant. So these are some of the critical congenital heart diseases. And one of the things that I also want to stress here is that oftentimes these things may not be as straightforward as we see them here. You just heard me mention about transposition of great arteries with intact ventricular septum. So it means sometimes you have transposition of great arteries if there is a ventricular septal defect, it is better than if you have an intact ventricular septum. So this kind of gives different faces to these conditions, the major underlying conditions, and define how their manifestations would be, and define also the approach that will be taken to treatment. Now, one of the lessons that I consider important to pass on with this presentation, cause of congenital heart diseases. The 7 defects we know if we're able to do them in our facility. And how do you do a pulse oximeter screening for congenital, cyanotic congenital heart disease? It is by simply using a pulse oximeter. And I just want to encourage us, the SpO2 saturation, oxygen saturation of an infant or of a baby or of any person has now become the 5th vital sign. We know about the temperature, we know about the pulse, we know about the respiratory rate, we know about the blood pressure. The SpO2 has become the 5th vital sign. And it's very important to say that even if these babies are not delivered in our own facilities, for them to have this screening in the immediate newborn period, I think somebody needs to mute themselves. Please, kindly mute yourself, please. Thank you. So, sorry. Even if we're not in the position to do a pulse oximetry screening for these babies in the newborn period, we can do it at any point that we meet them. We've seen this 4-month-old child that was presented in case 1. If this child in fact, this child had gone for vaccinations, how many times to the hospital, had gone for other problems. If anybody had taken an opportunity to put a pulse oximeter on the finger of this baby, the person would have, found out that this baby was actually cyanotic. And we also remember that on black skin, you may not just tell cyanosis by just looking, but on very first skin, you can tell oftentimes by looking because of the contrasting color between their white color and the bluish color. But we are dark skinned, so when we are dark skinned, it's more difficult to pick up. So this is the kind of a sample screening algorithm for cyanotic congenital heart disease. So it's advised that somebody's microphone is making a lot of noise. So it is advised that.
Hello, Chinima. Here, just 1 minute. Can Femi V91, please mute your microphone or I will disconnect you. Please go ahead. Here.
I'm not sure. Just a minute, I need to go back on my. So, well, essentially, the important thing is to screen by putting a pulse oximeter on the right hand and the right foot of the child. Advise several to do that at least after 24 hours of age. Doing after 24 hours of age allows some kind of settlement of the transitional circulation, so that whatever SQ2 that you're getting can be interpreted as correct. But this is where you're in the borderline, where you're having an SQ2 of 50, 60, like in the child that was presented in the second case at 5 hours of life. It's clearly a case that needs to be taken up and investigated immediately, not to wait until 24 hours old. So the normal thing, past screen means that any screening you have a saturation that is at least 95% in the right hand or the right foot, and with less than or equal to 3% absolute difference between the right hand and the right foot. It's important to say that pulse oximetry does not detect all critical congenital heart disease. So it's possible for a baby to pass this screening and say, but at least it will detect many of them, and it is not expensive to do. Now, some people would say, I don't have a pulse oximeter that can be used on a neonate or a newborn. Yes, but we have simple handheld pulse oximeters that you can get for as cheap as 60-something thousand naira, less than 70,000 naira, with a pediatric probe that you can use to screen smaller children. It mustn't be a neonatal probe, but there is a pediatric probe on that handheld pulse oximeter, which you can use and carefully So I was logged out on one device. I will continue with this one until I get back on the other one. Can you hear me, please?
Yes, we can hear you.
Yes, please go ahead.
Okay, yes. So, but you may not be seeing the screen now, but once the other one comes up, you will begin to see. So, it is important when you're looking at the pulse, when you're taking the pulse oximeter reading of a child, to ensure that the child is not crying. If the child is not crying, you're likely to get a reading that is misleading. It is important to look at the wave. There's something like a sine wave that moves on the screen of your pulse oximeter to ensure that that wave is picking up a steady wave, and it's not a wave that comes and goes or that is flat and haphazard. When you have it flat and haphazard, the reading you're getting may also be misleading. Some of them have like a bar that goes up and down. It gives you an idea of how much the sensor is picking, the saturation, the measuring of the differential hemoglobin, hemoglobinated red blood cells that the sensor is picking, So it gives you a sense of how much the sensor is picking. So those bars that are going up and going down, the red bars that will go up and go down, you have to make sure that those bars are going up, and then you're sure that your sensor is picking up what it's supposed to pick. So you don't just put a pulse oximeter reading and then read off any value you see immediately. It's also important to say that when you're reading a pulse oximeter, you should allow at least 2 minutes or 3 minutes to pass so that you can get what is fairly closest to the actual reading. It is because some pulse oximeters, once you put it on, they will begin from a very high value, 90%, 99%, 100, and then they'll begin to settle down to the actual value. For some, they'll begin to read from a low value and then begin to go up. So you don't know which one your pulse oximeter does. So once you put it and you see 100, don't just copy it and write down 100. And that is why it's important for us to also train our nurses who are taking the vital signs for us and make sure that the oxygen saturation that they're giving us can be relied upon. I think it is a very important takeaway from this conversation. Then,
Recording in progress.
okay, my second device is starting. I'm not sure if you can see my screen now. Another lesson to take away from this conversation is that we should look at all our results carefully, interpreting and connecting their clinical connotations. One of the things that struck me when I saw this child's investigation was a packed cell volume of 52% in a 4-month-old. And immediately I said, this child is having a polycythemia, and this polycythemia is resulting from chronic hypoxemia. So some of these things, you don't just see them and say, this child is doing well. No, interpret all your results carefully. Try to connect them to what they mean clinically, to the patient. Then the key lesson 2 is appreciating the presence of a cardiac murmur. It is easy and anybody can miss a murmur. But one of the things that I would also advise from this meeting is that the original Littmann stethoscope has an audio CD that it comes with, and it's usually a very good help, to use in learning about murmurs and listening to murmurs and all that. And there are also other resources that are found online. The key lesson 3, like I've explained and emphasized earlier, is to take complete vital signs. And like I said before, the SpO2 has become the 5th vital sign, and we should check it routinely and ensure that our nurses know how to use it. The third one is ECG interpretation. I think every pediatrician should be able to look at an ECG, say whether it is normal, grossly, what is normal and what looks abnormal. It's not too difficult to say or to see, because we have what we call ECG patterns. You can learn it with ECG patterns. This and this together, when you put it together, it means this. This and this together means this. We should have that, broad knowledge about that. And there are any times that we need to also take up other resources in order to refresh our memory on that. It's a very important thing to do as well. Thank you for listening, and I hope I have been able to stimulate our, appetite for this area of pediatric practice. And I have also reminded us about what I'm sure we already knew, but we've just been reminded about some of the key things that we also need to have on the tip of our fingers as we see our patients every day. Once again, I want to thank the private pediatrician group, Dr. Femi Mobalaji-Lawal, Dr. Olasende Letu, for giving me the opportunity to make this presentation. And I want to thank my colleagues. I have seen a lot of pediatric cardiologists joining this presentation. I want to thank you all for coming. And I also want to thank all of you for being here and for listening to the end. Thank you.
Thank you very much, Chinyere. That was a great reminder for a few of us who've forgotten about pediatric cardiology. I will hand over to Dr. Odudu to moderate next session. Dr. Odudu, over to you.
Well, thank you very much, sir. Hope you can hear me.
Yes, we
Hello,
can.
sir?
Yes.
Very well, good. Great. So once again, to join in thanking Chinyere, my very good friend, for this presentation. Very good reminders and giving us some key lessons to follow, the fifth vital sign, pulse oximetry, giving us a very great suggestion as to how we can use that in screening babies before they leave hospital. Another key things, the fourth key lesson was one that I found a bit mind-boggling, the ECG. Because once you don't do that regularly, it tends to disappear very quickly from your memory and from your practice. But nonetheless, my duty first is to ask for questions. I'm happy that she had mentioned that there are other paid cardiologists in the group. I'm sure they'll be able to also either questions, comments, to highlight some of the points she has made or throw more light into others. That would be very welcome. So please, I will ask that those who have questions will indicate by a show of hand, and the floor will be given to them. They can unmute themselves and ask their questions, or those who have comments to make, they will welcome as well. So the floor is open, please. Questions, comments?
Hello, Chinyere, can I ask a question? Just for the benefit of those of us in private practice, how much is it to do a pediatric echo? What's the cost of doing a pediatric echo? Thank you.
Thank you. Well, it's a ton, but it costs more if it will have to be mobile. For instance, in instances where the baby is unstable and cannot be moved at all. For instance, the second case that was presented was doing 50 to 60% on oxygen in the hospital where the baby was born. And it will really be very difficult to move that kind of baby to any place for investigation. So such cases would cost more.
Okay. Thank you. I see a hand up here.
And it depends on the location where they are.
Can I, Davis with blessing? Your hands are up. You can unmute yourself and ask a question.
Okay. Good afternoon, all. Good afternoon, Dr. Zodema and all the organizers of this. I really appreciate it. My question is on the criteria for passing for cyanotic congenital heart disease or not. So I used to know that it has to do with something pre-ductal and post-ductal. So what I know is you would do in the right hand, which serves as a pre-ductal, and then the foot as the post-ductal, since the left hand is indeterminate. But from your slides, I got to see that you do either in the right hand or either the hands or the foot. It's a bit, I didn't get it so well. And then if there's a difference of less than 3%, that means a pass. So if the difference is greater than 3%, I just wanted a little more light on that. Is it that we can compare with the 2 foot or the 2 hands? Or I just wanted you to throw some light on that. Thank you, Ma.
Over to you, Sharon.
Okay, thank you. Okay, so thank you for that question, Dr. Udemezu Blessing. The pre-ductal and the post-ductal derive from a relationship of the right arm or the right hand and the right foot with respect to the positioning of the ductus arteriosus in the anatomy of the aortic arch. Now, I was trying to see if I could get an image of that. If I do, I will show it before the end of the meeting. So a preductal is preductal, and it is on the right hand because the right subclavian and the right brachiocephalic, which supplies the right upper limb, takes off its origin before the position of the ductus arteriosus, and therefore it is called a preductal SpO2 on the right hand. Now, the postductal means that it is beyond or distal to the position of the ductus arteriosus on that aortic arch. So on the right foot is the postductal. So what we are saying is that it's not that you will do either this or this, you will do both, the right hand and the right foot. And for both of them, you must get a saturation that is at least 95%. And if you get a value that is less than 90%, you will redo it. If you get a value that is less than 90%, that value less than 90% is a failed screen. But if you're getting a value that is less than 95, that is between 90 to 95, it is also a sign that you have to redo it, at least separated by 1 hour. Do it 3 times. And if it remains persistently below 95% for that 3 times, move that child on for the next stage of screening to have an echo, for instance, and identify why the child is having a saturation less than 95%. Now, comparison of the preductal and postductal, we're saying that you should not have more than 3% absolute difference between the preductal and the postductal. I don't know if that is clear. So past screen should have 95% and above preductal and postductal. And the difference between the preductal and postductal should not be greater than 3% absolute value. Failed screen is you're having less than 90% on any of the limbs. So 89, 87, 88, anything less than 90 on any of the limbs is a failed screen. You have 90 to 95% on any of the limbs. You repeat it 3 times separated by 1 hour. And if it is persistently so, it is a failed test. Or you're having the difference between the preductal and the postductal greater than 3%. I hope I've answered your question. Thank you.
Thank you, ma. Yes, ma. Thank you.
Okay, so thank you very much. We have also Dr. Fagelu's hand is up, so she may proceed to ask her question. Dr. Fagelu, please.
Thank you, Dr. Odudu. Good afternoon, everyone. And Dr. Uzodimma, well done for that excellent presentation. I didn't expect anything less from you. Now, I have a comment, and my comment is that concerning congenital heart lesions, I think the major problem for us is access to urgent echoes for most of these children. So a lot of them are born, they are cyanosed. So everybody is thinking, oh, there's an oxygen problem. Of course, they put them on oxygen, and they're on oxygen for day 1, day 2, they're not getting better. Meanwhile, we're closing the ductus that is even keeping them alive. And some of them will just succumb after the 2nd or 3rd day. And you're thinking, oh, it's a respiratory condition, respiratory distress syndrome, all sorts of things, diagnosis. Now, the issue is, even when you are able to do, for places where they're able to make that diagnosis, getting access to immediate surgery, okay? Because if you start them on prostaglandin and there's no access to immediate surgery, either because of the facility or funds, which is a major challenge for most of our patients, they can't even afford the cost of surgery. So how long are you going to put these children on prostaglandins for to try and keep the PDA open? I think that's one major challenge when it comes to managing newborns with congenital heart diseases. So the thing for us is to advocate for these services to be made available readily and also made accessible either by subsidizing the cost of these surgeries for these children, especially those that have the critical congenital heart lesions. Otherwise, we're going to keep losing a lot of them. Those that have lesions that they can hold on till 3, 4, 5 months before the parents finally are able to raise money, they're fine. But those that have critical conditions, then they need to be operated early. So we need to make sure those facilities are available and also accessible to them. Thank you very much.
Okay.
Thank you, Dr.
All right, any
Okanjo.
more questions, comments?
I cannot agree less with you. Thank you.
Just so one answer, sorry, before you go on, Dr. Leto, please, if you look at your private chat, there's a message you may want to deal with. I just want to maybe
hello.
Ask, hello. Sorry, I see Dr. Lawa's hand up. I'll be with you in a minute. Just to ask a question with to Dr. Well, a question or comment. Anything the comment from Dr. Zodima. You're talking about screening with the pulse oximeter. Maybe it's important you comment about what is expected of the saturation levels in the first moments of life, so that we don't get unduly worried. People are not getting values in the neighborhood of above 93, 95 in the first 20 to 30 minutes of life when the child is being screened. Maybe you combine that with the question or comment from Dr. Mobulaji Lawal. Sir, you have the floor.
Okay, thank you very much, Leo. First, let me congratulate Dr. Uzodimma for an excellent presentation. I like the way you address both pediatric cardiologists, the general pediatrician, and also advise on what the nurses and medical officers can do. And I think this is very important take home for everyone, that, you know, these are the kind of things we like to have at these meetings, because when you are looking after these babies, it's a teamwork. And oftentimes, you don't have to be there as the pediatrician for the team that is working with you to have an index of suspicion and pick up things that they will be able to relate to you. So thank you very much for a very good presentation that covers everybody. We need to know more about little things that can be done urgently to save lives. And in that regard, I would like to encourage us all to please invite residents that are working with us, younger doctors and nurses, to this meeting, even you know, some other clinicians who are working to this meeting, so that they can also learn what they can do in the absence of the pediatrician to raise concerns, as the case may be. I have two questions, one to you and then one to the general house, Dr. Zodima. The first one is, where do you operate these children? Where do you send them to operation? Recently, I attended a meeting where there's a group of cardiothoracic surgeons who have some setup. I wonder where you operate your cases. Can you please let us know? And the second question is actually to everybody and also to you. You know, it's very heart-rendering to hear that somebody had to take a baby away because he cannot afford the care, and and that was it. And I know that there used to be, or there are, some NGOs or some groups that can fund this kind of treatment. I wonder if you know of any, or if anybody at the meeting know of any, because it would be good for us to know of them should we encounter such cases, because some of them may just have opportunity to save these babies. Thank you very much for a job well done again.
Here, over to you.
Thank you very much. Yeah, thank you very much, sir. Number one is when we are faced with these conditions, I think the pediatric cardiology team in Nigeria, the group as a professional, as a group of professionals, is actually doing a lot to improve the lot of children with congenital heart diseases. We have a WhatsApp group where we are able to communicate with each other. So what you don't have and somebody else can offer, it is easy for you to know. We also have the Nigerian Cardiac Society group where we are all in the same group with the pediatric cardiac surgeons in the whole of Nigeria. So sometimes you have a situation and you want to know, is there any facility that can handle this? You can easily have access to do that and you can easily get answers to what can be done. In this particular case, that second case we presented, I had surgery on the second day of life. The child was operated in Tri-State. It was Dr. Sanis who did that BT shunt. BT shunt is not a complex procedure. It's also a procedure that can be obtained in some other centers in Nigeria. And it's a temporizing procedure, it's a life-saving procedure. So sometimes we may think that, once it has come to this, the baby is destined to die. I was very happy to find out that at least the baby is not destined to die because they can have a life-saving intervention done, in the immediacy. And at that time, it cost them about 1.5, which was not so much, to keep a baby alive until later on. So what I say to that is, the pediatric cardiologist involved in management of this child has access to resources of colleagues in order to be able to know where and what can be done. Then, secondly, just to mention that there are a couple of centers in Nigeria that can do a lot, that can do something on cardiac problems. For instance, you can easily close a PDA in many centers in Nigeria if you have an isolated PDA. Federal Medical Center Abeokuta can do it. I have to start with it because that's my center. University College Hospital Ibadan can do it. University of Ife can do it. LUTH can do it. LASUT can do it. PDA closure is a simple closure. It doesn't require a heart-lung machine. It's not an open heart procedure. So there are even sometimes that you see a child with a very large PDA that needs to be operated within 1 month. The child cannot come out of failure with medical treatment unless you ligate the PDA. I've had one such case, I think 2 or 3 years ago, born with a very large PDA, and all the drugs were at peak, and the heart failure could not be controlled. And the child was persistently on oxygen. As at that time, I had to move the child to University College Hospital in Ibadan, UCH Ibadan. They ligated the PDA, and the child is fine today. So it's, like I said, the pediatric cardiologist involved. Well, be able to advise on the sources that is available, everything. But the unfortunate thing is that it is not the way we hear them. Some people say, call Can Heart Foundation. If you call Can Heart Foundation, they're not going to give you money. They're going to ask you, who are the people you know that you can ask for money that can help you? You will give them the list, and they will prepare a letter from their office and send to those people on your behalf. Then when they answer, they will answer you. So it's not a platform you can use to address critical problems like this. However, one thing that I often tell parents is, go to your community. You're coming from a community of families, because we live in a country where people want to be secretive about a lot of things. Somebody has a child with a problem, doesn't want the husband's brothers to know or the sisters to know. Go to your community, your family, that your first backbone, and tell them that you have a problem and see how they can help you. Then for the newborn, within the first 24 hours of life, any saturation that is less than, so more suspicious that saturation is. If it is less than 90, it is suspicious. You will have to continue monitoring the saturation of that baby to see whether that saturation improves or whether it continues to go down. If it continues to go down, just like the child we presented in the second case, that child should be moved and it should be triggered for that child to have an echo for a definitive diagnosis to be done rather than waiting for 24 hours. Thank you.
Thank you very much, Dr. Ozodimma. I wonder if there are other hands up. I cannot see any. With that, it's almost 4 o'clock. I want to thank you very much again, Dr. Ozodimma, for this presentation and for stimulating us again to some basic things, and also challenging us to look further to help children who have congenital heart defects. I will thank participants for patiently listening, and we are encouraged by the number of people who are filling up to this presentation, and we hope more pediatricians will join our ranks. Gladly hand you over back to Dr. Netu for the final remarks, and we can close. Dr. Netu, please.
Thank you very much, Leo. On behalf of Dr. Mobolaji Lawal and the other members of the coordinating group, I want to say a big thank you to Chinyere for doing justice to the presentation today. As you know, we have these meetings usually on the last Thursday of each month, and we're looking and soliciting for presenters for the months of October, November, and December. If you would like to present, kindly send a message to me or Dr. Mobolaji Lawal, and then we can arrange, set up the process of the presentation. Once again, Chinyere, thank you very much. Even though the notice was short, but you did put up a great presentation. And I know that it was challenging for you because you also had your personal challenges, which you told me about. And I'm happy that they're on the right track. So thank you very much. And to each and every one of us, thank you very much for listening. Bye-bye.
Bye-bye. Bye.
Bye-bye.
Thank you, everyone. Thank you.
Thanks. Bye.
Bye-bye.